The subject of forceps selection and application is a difficult one to present to students of obstetrics. However, we are fortunate in having a national authority on the subject of the choice of instrument. Dr. Edward H. Dennen is consultant to the Surgeon General of the Army, professor of obstetrics and gynecology, director of the department and attending obstetrician at the New York Polyclinic Medical School and Hospital. He is professor of clinical obstetrics and gynecology, Cornell Medical College, and attending obstetrician and gynecologist at the New York Hospital. Dr. Dennen will discuss the prerequisites for forceps deliveries and the classification of forceps deliveries according to the station of the head in the pelvis. Dr. Dennen.
Thank you, Colonel Reaver. Detailed instruction in the use of the various types of obstetrical forceps is difficult to obtain. The old adage, taught for years, learn how to use one type of forceps and use it well, has done much to retard the interest in other types, despite their admitted advantages under certain conditions. Also, designers of forceps and their satellites and students who became teachers taught only the use of their favorite type. Other types were ignored except to emphasize their disadvantages. The numerous types in general use shows that there is no universal forceps. Many an operator has experienced the sense of relief and the thrill of success following the use of one type of forceps after failure with another type on the same case. There were reasons present why one pair of forceps succeeded after another had failed. These reasons represent the advantages of the former and the disadvantages of the latter. With the advent of special types of forceps, more advantages appeared as well as more disadvantages. Also, different techniques of application and traction were required. A thorough knowledge of the advantages and disadvantages of the various types of forceps and the technique of their use will eliminate many of the bad results following blind faith in one type or the trial and error method. The ultimate object of this film is to show there is a choice of instrument in delivery with forceps depending upon the existing conditions, that one should choose the type of forceps that suits the case, rather than try to make all cases fit one type of forceps. To help in accomplishing this object, the various types of forceps are classified. Their style of construction is stated. The advantages and disadvantages of each are emphasized. A detailed description of the technique of the application and the traction for each type is given. Included are the maneuvers of rotation and flexion as indicated by the shape, position, attitude and station of the head and the type of pelvis. The 8 positions in which the fetal occiput may lie at the time of operation are taken up in order. The different operations and maneuvers and the choice of instrument for each position are described. To get the best results in a forceps operation, there are certain fundamental rules which must be adhered to. First, it must be considered as a surgical procedure, and as such, it should be given the thought, attention, dignity, and respect accorded to any other branch of surgery. It should be done by a trained, coordinated operating team. A forceps delivery certainly deserves as much trained attention as is given the average vaginal gynecological operation. Any operator does a better job with less risk and less effort if he has good assistance proper delivery room armamentarium, and well-supervised anesthesia. Now let us take up the major prerequisites for forceps deliveries. 1, the head should be engaged. 2, the cervix should be fully dilated. 3, the exact position of the head should be determined. 4, the type of pelvis should be known. And 5, the operator should be familiar with the advantages and disadvantages of the different types of instrument and the technique of their use. There are exceptions to all these prerequisites. However, they are rare, and when they occur, they deserve expert attention. An unengaged head in almost all instances is considered as a contraindication to a forceps delivery. The risks to both the mother and the baby make it unwarranted. The deeper the engagement, the better. As the lower the head, the easier and the safer the operation. Full dilatation of the cervix in most cases is essential to a successful operation. In complicated cases requiring a forceps delivery with a well-effaced, flaccid, soft cervix, digital manipulation may bring the cervix to full dilatation. In the rigid, resistant, non-negotiable type of cervix, occasionally one may resort to incisions of the cervix. However, this procedure is distinctly contraindicated if the head is not well down in the pelvis and the cervix is not fully effaced. A correct diagnosis of the position of the head is necessary in order to get an accurate application. If one does not have an accurate application, one is apt to give uneven pressure on the fetal head, and there's a wider diameter, a descending part, causing more risk of injury to the mother as well as to the child. Most heads should be in the anterior OA position at the time of delivery. If not so, they must be rotated to anterior, either instrumentally or manually. If one does not know the exact position, one cannot get an accurate application. It's not easy to determine the exact position. As the fontanelles may be obscured by molding, edema, and caput formation. If we consider this problem from the standpoint of the sutures rather than the size and the shape of the fontanelles, it may simplify it. We think of the sagittal suture, the two halves of the lambdoidal suture joining together to form a Y as the boundary of the posterior fontanelle. Hence, with the upright Y to the left, we have an LOA. With the inverted Y to the right, we have an ROP, or transverse Y to the left is an LOT. Occasionally, in tracing the sagittal suture to its opposite extremity, and this is important because the anterior fontanelle is usually more readily identified since it is bounded by 4 lines in the form of a cross. The sagittal suture and its extension, the frontal suture, bisected by the 2 halves of the coronal suture. Occasionally, on tracing the sagittal suture to its other extremity, it will be found that the sagittal suture curves upward. so that both extremities are in an anterior quadrant. And a position which is originally diagnosed as a LOA, with the posterior fontanelle above the transverse plane, also has the anterior fontanelle with its frontal suture dipping upward in the anterior quadrant on the right. This should be recognized as an anterior parietal presentation, with the anterior parietal bone presenting. The sagittal suture takes the form of the letter U, with its most dependent portion close to the sacrum, then the symphysis. And on examination, the fingers come in direct contact with the anterior parietal bone, and they must be dipped backward toward the sacrum in order to locate this U-shaped sagittal suture. So, in this situation, we really have an LOT presentation, which originally was considered as an LOA when the tracing of the sagittal suture was not continued to its extremity in the anterior fontanelle. Less frequently, the reverse of this situation is found, in which the posterior parietal bone is presenting, and the sagittal suture takes the form of an inverted U, with both extremities dipping downward into lower quadrants. Here we have the posterior parietal presentation with an LOT position and its posterior asynclitism. The subject of asynclitism may be illustrated by the following figures. Represents normal asynclitism of an LOT position with the sagittal suture a straight line. An LOT with an anterior parietal presentation due to anterior asynclitism. Here the anterior parietal bone presents, and the sagittal suture is represented by the figure U, with its most dependent portion closer to the sacrum than the symphysis, and its extremities extending upward into the upper quadrants. An LOT with a posterior parietal presentation due to the posterior asynclitism. Here the posterior parietal bone is presenting, and the sagittal suture is an inverted U with its superior point closer to the symphysis than the sacrum, and each extremity is dipping downward into the lower quadrants. The knowledge of the type and size of the pelvis is important in order to rule out cephalopelvic disproportion. X-ray determination is important as an aid in making this decision. It should help show whether there is cephalopelvic disproportion, which in true cephalopelvic disproportion, it's a contraindication to forceps delivery. It also helps in the diagnosis of position as well as in station. However, the clinical experience is important to add to the X-ray findings, particularly in the lower half of the pelvis. If one recognizes a platypeloid type of pelvis with a short AP diameter, it's usually accompanied by descent in the transverse with asynclitism, and one has to decide whether correction of asynclitism should be carried out, whether a cephalopelvic disproportion is present. Deformities lower down in the pelvis, often unrecognized clinically at the level of the mid-pelvis, may be seen on the X-ray. The deformed sacrum, the straight sacrum, or the forward jutting upper sacral segment, shortening the AP diameter. Here the mechanism of descent is the same as for the inlet of the flat pelvis, the platypelloid type, only at the lower level. And again, the same decisions have to be made as to whether to attempt a forceps. At a forceps of this level, this would be the mid-forceps, and this is the one that has received so much attention recently and is considered to be perhaps unwarranted. However, the X-ray findings can help us in deciding whether true cephalopelvic disproportion is present. Prominent ischial spines and also prominent coccyx, rigid coccyx, will call for decisions for delivery. Not infrequently, one has to rotate a head, which is in the OA position, instrumentally back to the original LOA or OA or ROA position in order to have the head pass this short AP diameter of the outlet.